Welcome to Guts in the Virtual Community, everyone. My name is Emily Pack-Hewitt, and I'll be your host for tonight. Guts in the Virtual Community is a monthly event hosted by the Georgetown Howard University Center for Clinical and Translational Science. Guts in the Virtual Community occurs every fourth Tuesday of every month. And the resources here that are shared are going to be elaborated on a little bit towards the end of the event. Next slide. So during the event, all microphones will be muted. If you have any questions or comments, please feel free to drop it in the chat. You may also email us using the email address in which we sent the registration link. You may also text us at 301-909-8135. Again, if you have any questions, feel free to drop it in the chat, email us, or text us at 301-909-8135. Next slide. If you would like to learn more about Guts in the Virtual Community, feel free to visit our webpage. I will also share that link in the chat. And we're also on Facebook, so feel free to follow us on Guts Community. Next slide. Guts in the Virtual Community is organized by collaborators from MedStar Health, Georgetown University, Howard University, the Washington, D.C. Veterans Administration Medical Center, as well as collaborators from the MedStar Center for Health Equity Research and our Participant Advisory Board, as well as our Community Advisory Board. Next slide. At this time, our speakers do not have any actual or potential conflicts of interest to disclose in relation to this presentation. Next slide. Our moderator for tonight is Dr. Joseph Verbalis. Dr. Joseph Verbalis has served as Professor of Medicine and Chief of the Division of Endocrinology and Metabolism at Georgetown University since 1995. He is also the Georgetown Director of the Georgetown Howard University Center for Clinical and Translational Science since 2010. Dr. Verbalis' research focuses on neuroendocrinology and has been continuously funded by the NIH for over 25 years. Dr. Verbalis, I'll hand it over to you.
Thanks, Emily. It's really a pleasure for me to be here with you all tonight. As an endocrinologist, I'm obviously delighted to engage in a program that talks about an important aspect of endocrinology, which is clinical research and what we learn from it and how it helps us to make better treatments for our patients and our patients to receive those treatments. So let's talk about exactly who we are and what we do. Next slide, Emily. So who are we? We're GUTS. GUTS stands, as Emily has already said, for the Georgetown Howard University Center for Clinical and Translational Science. And we'll describe that in a little more detail in the next slide. And then Karine Nassar will talk about what is health research and important questions that one should ask before joining a clinical research study. And finally, given that it is Diabetes Alert Day, Dr. Jean Park will give you some additional details about the importance of clinical research for diabetic patients and specifically the study that she is running on patients with diabetic kidney disease. Next slide. So what's GUTS? So the staff put together this this cute slide. It takes guts to make a change. That in fact is one of the ways in which we came up with the acronym GUTS for who we are. So it really stands for the Georgetown Howard University Center for Clinical Translational Science, but it includes the term GUTS, which it does take fortitude, if you don't want to say guts, to make changes in how we practice medicine. So we're a partnership of 5 institutions. You can see them up in that little logo up on the top right of the screen. Georgetown Howard, MedStar Health Research Institute, Oak Ridge National Labs in Tennessee, and the DCVA. And we were created to transform clinical research so that new treatments and cures for diseases could be discovered, and not just discovered, but delivered to patients faster so that they could benefit more from those new treatments. Importantly, there are only 62 centers across the country like us that are funded with what we call a Clinical Translational Science Award by the National Institutes of Health. So we're one of a elite group of institutions that have been designated by the NIH to be experts in clinical and translational research. And we'll talk more about what clinical and translational research means during this presentation. So we support researchers who design and implement research that will we can't always say for sure, but we think will have a high impact on the health of all of our communities. But as exemplified by this program today, we also work to increase health research awareness in our communities. And our communities are you all that are listening to us today. Next slide. What is research? Well, we don't want to make things overly complicated. It's always a temptation to do that. So in a very easy to understand way, health research is the process of testing new ideas and treatments to find out how to prevent, diagnose, cure, or treat illness. And I would add to that, to find out how to do those things more quickly than we've done in the past. Because if it takes 30 years to find out a better treatment for a disease, that's not going to help you all today. We want to do all this in a quicker and more efficient fashion than historically has been done. Next slide. So we have a number of resources for you, the members of our community. One of them involves how you can be involved with participating in research projects. And I show two on this slide. There's a national organization called researchmatch.org. It brings together people who are trying to find research studies and clinical trials for them with the researchers who are looking for volunteers. So if you go to that website, researchmatch.org, it makes it easier for you to find the kind of research study that you or your family might be interested in to participate. And it's a great national organization. It doesn't take any commitment on your part to go and look and then decide whether you want to enter your name to be considered as a potential participant in future clinical research studies or ongoing clinical research studies. But then we also have a local resource, which we've created in GUTS called We Partner for Research, and you can see the URL for the website there. We did that to provide information on clinical trials ongoing in our communities for our community members that will give them local options to participate in research studies. Next slide. But in addition to those resources for allowing you to or enabling you to participate in research, we also have educational resources for you, of which this is one tonight. Let's talk about clinical research. This website, you can see the link at the bottom, was created for the community in order to provide ways for our community members, you, to understand the research terms that may be reported in the news. Because sometimes, we all know what they are, but not everyone in the community does. And so we help define those for you. We use research information to make, we teach you via that website how to use research information to make some personal health choices. We also let you know how to be informed about how people who take part in research are protected. And Karina is going to do that in just a little bit. And importantly, we enable you to know how to find a research study that's most appropriate for you or your family members. So an important educational resource that, again, freely available. Just go to the website and explore it, and you can find out how all we can help you understand about research. Next slide. Next slide. So, patients often ask, patients or non-patients, just people in general, what are the benefits of research? I mean, research we all think is important, but you need to know why we think it's important. So researchers have been able to advance health, such as finding better treatments for cancer and diabetes. We wouldn't have many of the treatments we use today if it weren't for research that discovered them and proved that they were beneficial to our patients. So some people take part in research to access new treatments for themselves. but others do it to improve the health of their family and friends, and many just take part in order to help discover ways to improve health for everyone, all of our community members in the future. Next slide. So I'm going to end here. I've given you just a very brief introduction to GUTS, who we are, what we do, why we think it's important. But now we're going to drill down a little bit deeper into clinical research, into what it consists of, if you become involved, what you need to know, and then a talk by Dr. Park about a specific research project in diabetes and kidney disease. So our next speaker is Corinne Nassar. She's a registered dietitian and diabetes care and educational specialist with a lot of experience in clinical research in diabetes as well as other diseases, and self-management education in diabetes. She's currently the program director at MedStar Diabetes Institute in Washington, D.C. She manages a very innovative diabetes bootcamp program to help diabetics improve their glucose control, as well as the MedStar Health and Patient Glycemic Control Task Force. So very experienced in diabetes and diabetes research, which she will tell you more about next. Corinne?
Thank you very much for the introduction, Dr. Verbalis, and thank you for inviting me to join this presentation. Next slide, please. So let's start by talking about what is a clinical trial and what is clinical research. A lot of times when we think about research, the first thing that comes to our mind is a lab with test tubes, people in lab coats looking in microscopes. And that is where research starts. But then at some point where enough information has been learned about a potential treatment in the lab, then it needs to move into a clinical trial, which is where the research study now is going to involve people. So we're going to step out from the lab and go into the clinical arena. And it is through clinical trials that researchers find new ways to improve treatment and to improve the quality of life of people with diseases. This is how we get all of the medications that we use in diabetes, the new treatments, the new pills, the new insulin. This is how they come about. They first go through a rigorous research process, many clinical trials, and every trial that ever takes place that involves people has a person in charge, usually a medical doctor, who is called the principal investigator. And for example, Dr. Park, who's going to speak later, is a principal investigator on many studies, as is Dr. Verbalis. Next slide, please. So what is a protocol? When the principal investigator is preparing a plan for a study, they are going to write out a protocol. And the protocol is the detailed document that explains what will be done during the study. And it goes over all the details. What is the goal of the study? What is being tested? How is it going to be tested? What happens during the study visit? Who is eligible to enroll in the study? What are the safeguards in place to protect patients that are enrolled? And it's also going to have information that helps the study team decide if the trial is right for you, if you are somebody who's interested in participating in a research study. Next slide, please. So you may get a call one day from a research coordinator, or you may be visiting your doctor during one of your regular appointments, and they may bring up to you a study that you might be interested in. And they might say, given your lab work or your diagnosis or the medications you're on, I would like to tell you about this clinical study that is taking place that you might be interested in. And they will give you some basic information about the study. And this is where you, as the patient, we encourage you to advocate for yourself and ask a lot of questions. So you're going to start by saying, well, why is the study being done? How will this study benefit me? And what risks are involved? How long is the study? This is very important. Before you sign up, you want to know, is this 5 weeks, 5 months, 5 years? Some studies go on for a very long time, and you just need to decide if this is the right fit for you. You also want to know what's going to be asked of you, because when you enroll in a clinical trial, there will be study visits that you have to attend, and then you will be asked to do certain things, whether it is to take medications or to take your blood sugars or weigh yourself or increase, change the way you eat, whatever it is you want to know. And then you also want to know if there will be any costs to you. Conversely, you may also ask, what is the study going to provide? Because, with diabetes studies, oftentimes the study provides blood glucose meters, supplies, study medication. So all of these are kind of the kind of question that you want to bring up as you're trying to make a decision whether you want to enroll in a study. Next slide. So you also want to ask, what happens if I don't get the new medicine or treatment? So most of the clinical studies that we do involve, well, not all, but many of them involve a placebo arm, which means that you will be randomized, meaning kind of like the flip of a coin, and you might get the treatment and you might not get the treatment. So you want to know what happens if I don't get the treatment. You also want to know, am I going to be asked to try a new medication that hasn't been used before? So you want to know what do we know about this study, about this study medication? How many people have tried it before? What is known about it? And then if you decline to participate, you want to know, how will my care be different if I don't participate? And the answer to this is always that you will get standard of care. So if you decide not to participate in a study, you're not going to be deprived of access to what is available right now or the regular care that you get from your physician and standard of care treatment. But you just would not be able to access the study medication. The other thing that is very important to know is that even if you decide to enroll in a research study, it is entirely up to you. And then you can decide to leave at some point during the study. So you have full control in that situation. Next slide, please. So let's say you've been approached about participating in a research study and you've asked these questions, and then you say, yeah, I'm going to come in and I want to enroll. The first thing that's going to happen before anything takes place in a study is you're going to be presented with an informed consent document. And this document is basically exactly what it says. We need to make sure that you are fully informed about what you will be signing up for before you sign up for it. So it's a document that you're asked to review and sign before you can do anything in the research study. It is the first step. And this document will explain to you in detail why the study is being done, why you may be a good candidate for the study, and what you will be asked to do if you choose to participate in the study. So there's usually either a table or a list that says, when you come in at visit 1, this is what's going to happen. And when you come in at visit 2, this is what we're going to ask. And maybe we're going to ask you to do this, that, and the other between visits. It will also list possible benefits and risks of taking part in this study. It will tell you who is in charge of the study. And a member of the study team, usually a research coordinator, will go over the consent with you and answer your questions. And that is what is called consenting. You will also be given the investigator's contact information, as well as contact information for the institutional review board that reviews and approves studies. So the Institutional Review Board is a board that is concerned with protecting study patients that are enrolled in clinical trials. They review protocols and they only approve them if they see that there is safety, safeguards in place to protect patients and that patients will be fully informed of what is going to happen in the study. Next slide, please. So another person that you can talk to try to decide if you want to enroll in a research study, or even if you are in the research study and you have concerns, then you can talk to somebody called a research participant advocate, or RPA. And this is someone who knows and understands clinical research, but is not part of any research study. So they're sort of like an independent counselor, if you will. And their job is to ensure that you are properly informed and protected as you participate in a research study. And remember that throughout this process, your participation is entirely voluntary and you may withdraw at any time. Next slide, please. So in addition to working with an RPA, there's many federal, state, and institutional regulations and policies that are in place to protect participants in clinical research. Many. Anybody who is involved in research has to go through extensive training to make sure that they're doing things properly. And then there are a lot of rules in place that need to be followed. The RPAs enhance these protections by advocating for study participants, and they act as a resource both for the investigator and they provide independent oversight to the study. They can also serve as an objective witness during the consenting process. They can answer your questions, and they can discuss your concerns at any time during your participation in research. Next slide, please. So how to contact a research participant advocate, there's information on this slide, and I am sure that this information can also be accessed on the, by emailing GUTS. There's many ways that you can connect with support if you are interested in participating, but maybe you're a little bit concerned, you're wondering what it means, and you just want more information. And also, after you enroll in a study, there is support and help for you. Next slide, please. And so to drill down a little bit on a specific subject here, diabetes is, what a lot of us on this in this presentation do, a subject that is near and dear to us. And we all know, or most of us know that kidney disease is one of the potential complications from diabetes. And there are many clinical research tests that are trying to understand, diagnose, prevent, and treat potential complications from diabetes. And one of them is kidney disease in type 2 diabetes. These studies could not be done without the people who agree to take part. So the participants, whom we call study volunteers, help us researchers find answers to many health questions. And GUTS aims to educate the community on clinical research so that people can make informed decisions when trying to decide whether to participate in a clinical research trial. And guidance on what questions to ask before participating in a clinical trial can be helpful. And knowing your rights as a study participant or volunteer is also very important. Next slide, please. So our next presenter is Dr. Jean Park, who is an endocrinologist, diabetes and metabolism specialist at MedStar Good Samaritan Hospital. She has a special interest in diabetes prevention and treating diabetes and kidney disease, in patients with diabetes. And she is currently serving as a principal investigator for a big study that is looking at the effects of 4 different glucose-lowering medications when combined with metformin. And she is going to be talking, presenting to us about specifically research in kidney disease and diabetes. Dr. Park?
Well, thank you for the nice introduction, Corinne, and big thanks to the GUTS team for inviting me to talk about diabetes and the research that we are conducting. Next slide. So the timing couldn't have been any better. Kudos to the GUTS team for having me talk on American Diabetes Association Alert Day. This is observed annually on the 4th Tuesday in March, and this is where we sit. It's the one day to do a wake-up call, quote unquote. We want the American public to know about the seriousness of diabetes. We're encouraging all to take the diabetes risk test, and we will go through that later or provide that opportunity later. And it's a time to learn about your family's history of diabetes. Next slide. And we also want to talk about the importance of research on this day. Clinical research studies play an important role in finding new treatments and approaches to manage diabetes. It has helped us discover ways to diagnose and prevent diabetes. Next slide. So before I go in further talking about diabetes and just providing general information, this is just a general outline of what I'll be talking about. Again, I'll be focusing more into diabetic kidney disease and management. Clinical research, we have specific questions and we're trying to find specific answers. So this is where we are. To do this for today, I wanted to go over general information about diabetes, going through risks for diabetes, the potential complications of diabetes, and focusing in on diabetic kidney disease, and how we can prevent complications or stave off progression in diseases or complications from diabetes. Monitoring and controlling blood glucoses are very important, and we'll be going over that. and again, trying to find answers through clinical research at our center this way. Next slide. So this is some general background about diabetes. Diabetes unfortunately affects a number of Americans, 34.2 million Americans, or about 10.5% of the US population. And nearly 1 in 5 adults are living with diabetes and are unaware that they have the disease. So that is 7.3 million Americans. Next slide. So the sooner you know you're at risk, the sooner you can take the steps to prevent or manage diabetes and stave off progression of or developing complications. So what are the risks? One is if you have a family history of diabetes, you have a greater chance of developing type 2 diabetes. Other risks are if you're over the age of 45, are overweight, if you're not physically active, if you have a history of hypertension, a history of polycystic ovarian disease, a history of depression. So there's a list, a number of risks involved with diabetes, and we provided a link to those risk factors with this slide. I believe it's in the chat. And then you can see on the right side that there is a test that I mentioned earlier that you could take to look into your risk for type 2 diabetes. So when you go through, or if you go through this test, if you score a 5 or above, you are at high risk for type 2 diabetes. You should talk with a provider, look into further testing, which could include blood tests to assess further. If you score below a 5, you may be in the pre-diabetes category, but again, to talk about it with the provider would be very important to look into blood tests and further testing so that you can find out about your diagnosis if there is. Next slide. So diabetes, unfortunately, there's an increased risk for many serious health problems with the condition, but the good news is that with correct treatment, talking with your providers, finding out what's best for you, and following the lifestyle changes, it can really, really make an impact in preventing or delaying the onset of complications, such as nerve damage, which we call neuropathy, eye damage or retinopathy, or kidney damage or nephropathy. Next slide. So as mentioned earlier, I am going to focus more in the complications potentially with chronic kidney disease or nephropathy from diabetes. So what happens at the level of the kidneys with high blood sugars or uncontrolled blood sugars, this makes the kidneys filter out too much blood. There's increased pressure at the filters, I call it, or sieve, when I talk to patients and participants. And unfortunately, all this extra work, it's hard on the filters, and over many years, what can happen is that proteins that are useful, that are supposed to stay in the blood, can be lost in the urine. So very early on, what can be seen through testing is microalbuminuria, when there's small amounts of protein in the urine. And this can't be seen with the naked eye. There can't be changes that you see in how much you urinate or the quality of the urine, because I often get that question from patients and participants. Next slide. Some other information about diabetes and chronic kidney disease. Kidney disease or nephropathy is one of the most frequent complications of diabetes, and nephropathy from diabetes is the leading cause of chronic kidney disease in the US, and it accounts for over 50% of cases in the developed world. And along with diabetic kidney disease or nephropathy, unfortunately, there's also a higher risk for morbidity and mortality due to cardiovascular disease, and as a result, costs of care can be fairly high. Next slide. So how do we try to stave off progression of a complication or a diabetic complication? That will be with monitoring and controlling blood glucose levels. And next slide. So how can we do it? How do we control blood glucose levels? And if we do it, what can we prevent? We do know that when we tighten glucose blood control, blood glucose control, or keep it in a good range, it can reduce that microalbuminuria I had mentioned earlier, which is that small amount of protein in the urine, by 1/3. Next slide. Also, if a patient or people have microalbuminuria already, you can reduce the risk of progression into higher amounts of protein in the urine called macroalbuminuria by 1/2 when you control blood glucose levels. Also, there have been studies that showed when you tighten glucose control, you can even reverse microalbuminuria. So all good news. When you can control your blood glucose levels, there is some staving off of progression of kidney disease. Next slide. So how can we do this? How do we measure blood glucose levels so that we know we're in good control or not? And this probably all looks fairly familiar to all of you, but there is 3, I say, broad categories of how you can monitor blood glucose levels. One is through a glucometer with finger sticks. Another is by hemoglobin A1C, which is a blood draw. And the newest kid on the block, I say, is by continuous glucose monitoring. I'm going to focus more on the hemoglobin A1C and CGM, since this is where we're looking into further with studies that we have going on at the center. Next slide. So hemoglobin A1C, just to give you a brief overview, it is a very reliable test. It's been a widely established measurement of glucose control in diabetes. It's the gold standard. So when a patient has a diagnosis of diabetes, to use this to say you're in good control or you need improved control, again, the gold standard. And you can see on the right side, we also use it for screening. And with the normal range, we call it, it's when the percentage score is lower. So if below 5.7. And when the number is higher for hemoglobin A1C, we could just say that your average glucoses are going to be higher. So with prediabetes, you can see the percentage is higher for range when at 5.7 to 6.4. And when you have a diagnosis of diabetes, it would be at 6.5% or higher. Now, if someone is asymptomatic, you would need to verify that another time to say a person may have diabetes. Next slide. So how do we know about glucose control through a hemoglobin A1C value? So hemoglobin A1C, it reflects the amount of glucose bound to hemoglobin in red blood cells, and red blood cells turn over every 2 to 3 months. So we know that the level of glycemic control, it's a reflection of the 2 or 3 months prior when we draw an A1C. Next slide. So again, I just said it's a gold standard, but there are some caveats, maybe some limitations when there's chronic kidney disease present. What we can see is that with chronic kidney disease, there can be accelerated red blood cell turnover. So the life of the red blood cell is going to be shorter. So there's less time for the glucose to attach to red blood cells. So potentially the A1C can be lower than expected. And an example that I can give is, say I may have an individual with chronic kidney disease. Perhaps their A1C could be 7%, which for us, it means an average blood glucose of 150s over the last 3 months, 2 to 3 months. But say you look at this person's CGM or finger stick glucoses, and could you potentially see averages that are a bit higher as a result of the accelerated red blood cell turnover? So just something to keep in mind. And the next slide. So again, we do monitoring of blood glucoses, management through CGM, or continuous glucose monitoring. And this is where an individual would wear a sensor on the skin, which could be placed on the abdomen, on the upper arm. And this one in particular is showing the Dexcom sensor. There is one that is called a Freestyle Libre sensor that is being used with the study that I will mention later on. And that one is a quarter-size white button that you may place on the back of the arm. And when that is placed, it is measuring the glucose in the interstitial fluid around fat cells. And there's an algorithm and an estimation of what the blood glucose is concurrently. The transmitter then wirelessly sends that information to a monitor. We can download all those glucose readings and gather a lot of information actually that way. Again, we are measuring glucose every few minutes, so a lot of the time periods that we may miss when a patient does finger sticks once or twice a day, we're now getting over the 24 hours per se. And then we can look at trends when a patient may have low blood glucoses or high glucoses. And we can also look at numbers like average glucoses and time in range. So it's a very helpful printout or report that we can get from someone who wears a CGM. And next slide. So for us, how are we trying to find an answer through clinical research? Next slide. We are conducting one study out of several or many studies at our center, which is interpreting glycemic control in people with type 2 diabetes and chronic kidney disease, glycemic control in type 2 diabetes and CKD for short. And the goal of this study is to look into the relationship between blood glucose as measured by CGM and A1C in patients with a certain level of chronic kidney disease and in patients who have type 2 diabetes. And patients who future participants are people who may have type 2 diabetes and can be on any medications or even diet controlled. It is funded through the Latham Fund, which supports projects throughout the DC metro area. Next slide. So with the help of the CGM device, we want to better understand if A1C values are significantly different in persons with diabetes and chronic kidney disease compared to the average glucose data captured from the CGM. And are these differences in average glucose and A1C dependent on stage of kidney disease? So that's a secondary aim we have there. Next slide. We are having this study being done at 2 separate sites within MedStar Community Clinical Research Center, or MCCRC, which is the scientific research center within MedStar Health Research Institute, the research arm of MedStar Health. So we are doing this at the University Town Center location in Hydesville, and then at MedStar Good Samaritan Hospital in Baltimore. Next slide. And if one should choose to be involved, you would have a placement of a continuous glucose monitoring device for continual glucose measurements over about 2 weeks. It can be 10 to 14 days. We are looking for 40 participants. And at the screening visit, we will proceed once information is provided, all the questions are answered, and as long as the patient provides consent. And we will do this prior to any study procedures. Next slide. So at the first visit, once consent is signed, we would draw a blood sample for an A1C and kidney function. And we may draw a sample for hemoglobin and hematocrit. And this depends on whether the participant already had these tests drawn within a month prior to the screening visit. You would attend 3 study visits over the course of 2 to 4 weeks, so a short study. Next slide. Just some more information about the CGM. It would be a blinded CGM, meaning that you won't be able to check your blood glucoses at the time you're wearing it. We would definitely go over all the information from the report after the study participation and also provide that information to endocrinologists or internists who are involved in the care of the participant. And this slide is about COVID-19 safety measures. We, of course, have had a number of questions around this and research participation. We are now a year going into COVID-19 pandemic, and we have been keeping up with this just as MedStar Health has throughout all of the hospitals and centers. Masks are mandatory. We do screening calls. And over time, of course, there have been protocols extending out to even converting clinic visits to phone visits at times. And the next slide. So if you're interested in learning more, would like to participate, please contact our research coordinator, O.C. Sanchez. Number is provided, or an email to O.C. Sanchez, and we'd be glad to talk to you more about our study. Thank you.
Thank you, Jean. I want to thank both you and Corinne for very clear explanations about clinical research in general and about diabetes research in particular. As an endocrinologist, I can just verify the importance of the study you're doing in diabetics with kidney disease. It's not just that there may not be as good a correlation between their glucose levels by continuous glucose monitoring and hemoglobin A1C, but also, as you know, and the audience should know, some of those who are diabetic, if they have kidney disease, the blood glucose levels can be much more what we call labile in patients with kidney disease. They can go up and down much more than in a diabetic without kidney disease. So this kind of study is key to understanding how we should better treat patients with diabetes and kidney disease. And that leads to some of the questions from the audience. And I will take, and again, please enter them into the chat and we will address them as we get to them. So Tasha Green wants to know, is there a way to prevent diabetes if you have prediabetes?
Yes, so there's so many ways to try to stave off progression, and that's why we were emphasizing early diagnosis or prevention, right? If you know about it, then you're going to work on it. So working on diet, exercise efforts, weight management, and there have been thoughts too of even using metformin to help staving off progression. So it's a continuum. You have, I say, a balancing act that you can't get away from, which is what, if your pancreas is producing a certain amount of insulin and your body wants a certain amount of insulin, it's always that balancing act. So all those risks that I mentioned for diabetes, if you can work on it, talk about it with the provider, look into ways to try to optimize some of the things to help with diet and weight and exercise, then I think that's the way to go.
So I think it's important for everyone to realize that this is not necessarily a preordained diagnosis of complications that are bound to happen, that people can take charge of their lifestyle and take actions that really will either prevent or certainly delay the onset of diabetes, even if they have prediabetes. So crucial to talk with providers of your healthcare, your PCP, your endocrinologist, if you have one, about that, so you can take the steps necessary before you come to the complications of diabetic kidney disease. So
can we also ask Corinne to, given that she's also a dietitian?
Sure, of course.
Yeah.
Well, what I second everything that you said, and what I would like to add is that the studies that have been done, you know, the diabetes prevention program, the results, it was done over a long period of time, and they're now in the extended phase. And what we're really seeing is that we're not talking about heroic measures, What the DPP showed is that if you lose between 5 to 10% of your weight, so in some instances it could be 15 to 20 pounds. We're not saying 50 pounds, or if you lose 5 to 10% of your weight and you exercise 5 times a week for a half hour to 45 minutes. And by exercise, I'm not saying bungee jumping. Most of the people in the study were walking. That's just what they did. They went out and they walked. So, increasing your exercise level to where you are active 5 days a week and you're changing the way you eat and you're losing a little bit of weight was shown to be very effective in reducing the risk of developing diabetes, or like Dr. Verbala said, delaying it for many more years. And there is great benefit in delaying, because you're also then delaying the potential complications that can happen with diabetes. So answer to your question, it can absolutely be done. You just get some help, go see a dietitian, talk to your provider, and get with working on it.
So Corinne, I think that's really important, that some people feel that in order to both treat diabetes and prevent it, they need to get their weight all the way down to a low level. And in fact, that's not true.
Exactly.
As I said, the studies have shown that even if you're starting from an overweight or even obese level in terms of your body weight, just that 5 to 10% reduction is going to be enough, even if you don't get down to a normal, what we call a normal body mass index or weight. That's sufficient to markedly retard the progression of diabetes from prediabetes to frank diabetes. So another question for Dr. Park. So this one is a loaded question. It has no simple answer, but that's what we deal with all the time. So which one is better to monitor my blood glucose, hemoglobin A1C or continuous glucose monitoring?
So I'm going to say it's probably a little bit of everything potentially, right? And I think it depends on where you are with your diabetes. So it is a loaded question. I'm going to say if you have someone who is diagnosed with diabetes, taking oral agents, and there's no risk of hypoglycemia, do you really need to monitor every day? I'm going to say no. That say you have someone on metformin doing very well with their diabetes, there really hasn't been data to say that you need to check your finger sticks every day. You could check every so often. Do you need something like a CGM to wear? No, I'm not going to agree with that either at that point. So it really depends where you are in your diabetes. And say you have diabetes and you do require use of insulin. Perhaps you're injecting 3 or 4 times a day or using an insulin pump. That you have type 2 diabetes or type 1 diabetes. There's a lot of factors involved, but if you are injecting insulin several times a day using an insulin pump, this is the other end of the spectrum, then perhaps it's an all of the above. You really do need that hemoglobin A1C value to see how you do over to give an average over the several months. But then to know the nuances daily, you would potentially need a CGM to help you to monitor what doses of insulin may need to be adjusted, when you need just the background insulin, when you need to provide insulin with meals. Having something like a CGM or multiple finger sticks would be helpful. But I would say it's a tough question to answer in a couple of lines. It really emphasizes the point that I say to my patients and participants, that diabetes is individualized. I can't say that there's one size fits all for diabetes and management. It really, I tell everyone that I see that I am thinking about you, who you're sitting in front of me, and this is what I have to do for you and recommend for you. So I hope it answers somewhat of that question that you asked.
But as always, it involves a discussion between the patient and the provider, again, whether it's their PCP or endocrinologist. That there often aren't simple answers, but that discussion can lead to deciding what's best for that patient at that point in time.
Yes, agree.
And I think that one of the great things about, well, not about diabetes per se, but the great things about diabetic care are the technological advances that have been made in diabetes care, such as continuous glucose monitoring. You mentioned insulin pumps in addition to injections. None of these things would have been possible without the clinical research that proved that they were effective and allowed the development of monitors that could be worn rather than big machines that you have to come into the hospital to have monitor your blood glucose. So I think we're at a great time in diabetes in terms of using technology to help manage our diabetic patients. And the study that you're doing is going to help address what the question that was answered: what is the best way to monitor your glucose in a diabetic patient with chronic kidney disease?
I agree. Thank you for that, Dr. Verbalis.
So do you want to project what the future of diabetes care will be from your perspective?
I think the technology part is going to play a bigger role as CGM and pump use gets better and better. It's hard to keep up sometimes. I mean, Corinne, I don't know if you feel the same. It's just that I feel like it changes every few months, but
Yes.
I feel like as technology gets better, we're going to learn more and more. There's going to be more studies, more data. There's going to be changes in recommendations. We're going to learn more about diabetes when there's particular conditions like chronic kidney disease in the elderly. And I just think we'll be able to modify perhaps recommendations as a result with the advances in technology. It's just been, I feel like, warp speed with how much that has changed.
I also think that really what we're going to be seeing in the future of diabetes care is, like you said, Dr. Verbalis, much more individualization, because the newest guidelines from the American Diabetes Association is not just about helping patients lower their blood sugars. It's also looking to see, do they also have kidney issues, or are they at risk for heart disease? And then we decide which treatments to work with and how to advance their medications based on this. So it's no longer, the thing that we're just focusing on is lowering blood sugar. We're also focusing much more on staving off the complications. And we have these new classes of medications, the GLP-1s and the SGLT2s, and all of these new classes we didn't have a few years ago, that allow us to refine how each patient receives their care.
Yeah, I think the virtual explosion in new therapies
Yes.
for type 2 diabetes, I don't see too many areas in medicine where that's been greater, other than perhaps control of hypertension. But we have so many more tools to help treat diabetic patients today. But again, in order to have access to those tools, you have to have those discussions with your providers about what's best for you, because some of them that you mentioned, both the SGLT2s and the GLP-1 agonists, also have the effect to decrease cardiovascular events.
Exactly.
And especially for the GLP-1s, have the ability, along with metformin, to decrease body weight, again,
Exactly.
to help patients accomplish that goal. And it has to be a multifactorial approach. So another question, can I, or should I, maybe should I is the most important part of that, start to monitor my blood glucose if I'm pre-diabetic? So how important is it for people with a diagnosis of pre-diabetes to actively monitor the blood sugar, either by finger sticks or something like CGM, as opposed to using the hemoglobin A1C?
At this time, I'm going to say that I wouldn't recommend monitoring blood glucoses regularly with prediabetes. The American Diabetes Association has recommended having A1Cs checked on a yearly basis. And this points to the fact that when you have prediabetes, it takes years usually to progress when you're in that stage, unless there's unforeseen circumstances that can affect you, any illnesses or medications that may come on board and cause insulin resistance. But other than that, it really does not move in progression very quickly. So I usually don't recommend my patients with prediabetes to actively check glucoses, but again, to have A1Cs checked, that is recommended. That would be what I would pursue for one of my patients. I think the next question was clinical studies. At this time, in our center, we do not have a particular study going for prediabetes. Dr. Verbalis, I know you had put out in your slides, if an individual is interested in any studies, they can put their name on that list. And if there's something coming through our centers, I think that would be a good way to start if you are interested.
But as Corinne had already mentioned, the study on a lifestyle modification, comparing that to drugs like metformin, really have already shown the benefits of doing that. So whether there is likely to be a more impactful study on prediabetes than what we've already seen, we never know, but certainly enough studies have already been done to prove the importance of lifestyle modifications in delaying or preventing diabetes developing from prediabetes.
I think there was a question from someone asking whether they could join a study at the same time as their wife, and I would say the answer is yes. Usually we don't have a problem with
You could bring friends in too. I mean,
yeah. As long as you meet the study criteria, we're fine.
okay.
I want to also add that, you could also go to, so Emily just put in the chat about trials today, and that is a good way to do searches for clinical trials. Trials Today is a little friendlier than clinicaltrials.gov, but because I know it, I went to clinicaltrials.gov and I put in prediabetes, and there's no current active studies, but there was one that was completed at GW on prediabetes and continuous blood sugar monitoring, glucose monitoring. So, so definitely look on these studies, clinicaltrials.gov or Trials Today, and Emily put that into the chat box.